Good evening, everyone, and welcome. Today we're joined by Mary O'Connor, diabetes nurse specialist and certified diabetes care and education specialist at Engwood Hospital. Mary will lead a candid discussion on weight loss medications and their role in diabetes management. If you have any questions during this presentation, please feel free to comment them in the Q&A box below. We will answer all of them at the end of the talk. Please join me in welcoming Mary O'Connor.
Good evening, everyone. I'd love to see you. Let's pretend we're like having a party together somewhere. And I'm, of course, like the fun one there, talking about some of these medications. All right, let me just get ready to share my screen. Okay, so let us begin. The topic is what's the skinny on the diabetes drugs and weight loss? It is a extremely hot topic today. If you think about it, you probably know a lot of people that are taking some of these weight loss medications. These weight loss medications actually started because they were kind of developed for diabetes. They found that they lower blood sugars. Then they also discovered, oh, wait a minute, there's some weight loss behind them. So now they're also used for weight management, not just for people with diabetes. But before I kind of get into the lecture on all these weight loss medications, I do want to give a little bit of an overview of diabetes because this is a topic on diabetes drugs, right? So when we talk about diabetes, we're primarily talking about two types, type 1 and type 2 diabetes. Totally different animals, all right? Person with type 1 diabetes actually needs to take insulin for survival, and insulin is a hormone that regulates blood sugars. And an easy way to describe it is insulin is the key that unlocks the cell doors, and all of the cell doors need glucose in order to function. In type 1 diabetes, no keys are being made, so all of the sugar is sitting outside the cells, not going into the cells. Have to take insulin for survival. Type 2 diabetes, there's a few different things that go on with type 2 diabetes. Person is still producing insulin, but the key is not fitting the lock as well as it's supposed to. And that's ultimately what we call insulin resistance. So again, type 1, person is not producing any insulin, counts for about 5 to 10% of people with diabetes, and it is autoimmune. One of the things that we're finding sometimes with type 1 diabetes, and some of you in the audience may have what we call LADA, latent autoimmune diabetes in adults. It's a slower progression of type 1, and a lot of times people will present looking as if they're type 2. So sometimes somebody with type 1 may be given some of these diabetes medications for weight loss, assuming, maybe the physician is assuming that they are type 2. Type 2, remember, your insulin isn't working as effectively as it should. And on top of that, you're not quite making enough insulin. So it's a little bit of a double whammy. The third type of diabetes that is more common is gestational diabetes. That's found during pregnancy. So you men, you don't need to worry about that, okay? But about 50% of the women with gestational diabetes will go on to develop type 2 diabetes. So let's talk about the risk factors really for developing insulin resistance or primarily type 2 diabetes. Insulin resistance a lot of times is also known as pre-diabetes. So some of you in the audience, you might have some of these factors. Anybody older than 45? That puts me at a risk factor. Overweight, that's another risk factor. Sedentary lifestyle, how many of you are up and walking or exercising 30 minutes at least 5 days a week? Family history of diabetes, we know that it definitely can be inherited. Heart disease or stroke, high blood pressure, cholesterol issues, sleep apnea or insomnia. Every time again I turn around, somebody ends up with sleep apnea. For women, PCOS, polycystic ovary syndrome, which is insulin resistance, and metabolic dysfunction associated liver disease, which is another way of saying fatty liver disease. We changed the name a little bit. So how do we make that diagnosis of diabetes? First test that's typically done for type 1 or type 2 is we may do what we call an A1C. And for those of you that are watching that have diabetes, I hope you all know exactly what your most recent A1C is, because that gives you a little bit of a good benchmark as to what is going on. Somebody without diabetes is going to have an A1C less than 5%. 5.7 to 6.4 is considered pre-diabetes. 6.5 to 7, excuse me, 6.5 to 7% is considered pre-diabetes, sorry. 7.5 or 7% and higher is considered diabetes. Now, some people might have a 6.5, 6.6 and a new diagnosis. Maybe if you work on some lifestyle behavior changes, you may be able to blow that and get it back down to a non-diabetic level. The A1C is a reflection actually over the last 2 or 3 months. It's not just when you do a blood sugar. The blood sugar is your now moment. My blood sugar right now could be 84. My blood sugar right now could be 180. On the other hand, the A1C is an average of glucose over time. The A1C, what happens is glucose binds to the hemoglobin molecule. All right, so we have all the sugar around the hemoglobin molecule. The lifespan of a molecule is hemoglobin molecule is roughly 2 to 3 months. So when we do the A1C, we're actually looking at how much sugar is around the molecules. Once you're diagnosed, the frequency of the test is usually every 3 to 6 months. In somebody with type 1, we may do it every 3 months. Somebody with well-controlled type 2, we may do it at every 6 months, sometimes even a year. The higher the number, the greater the over time, the greater the chance of developing complications associated with diabetes. We want to lower the A1C. We want to keep you healthy. That reduces the risk of heart disease, kidney disease, nerve damage. So again, what is the goal of the A1C? 5.7 to 6.4 is pre-diabetes. That means you better get it in gear and try to blow this thing away. The sooner you find out about diabetes, maybe your blood sugar level is only slightly elevated, the greater the chance of reversing it. Right? When someone's had diabetes over a long period of time, especially uncontrolled diabetes, it's much harder to control that diabetes over time. A1C of 7% or higher is definitely somebody needs to take action. Typically, we say the goal for someone's A1C is under 7%, but that is definitely very, very individualized. It's based on age, maybe what is the risk for someone getting hypoglycemia or low blood sugar. If someone's on medications that may create low blood sugar, they live alone, they have nobody there if their sugar did go low, we may be looking for a little bit of a higher A1C. For children run around like they're crazy. Right? And we know that exercise lowers blood sugars. So for children, we may actually leave that number a little bit higher until they get older and more realistic in their activity and more conscious of what they actually need to do. So how do we manage diabetes? Type 1 is insulin. Person is not making any insulin, they must take it for survival. Insulin can be given multiple times during the day. There's insulin pumps today that people can wear. We also talk about healthy eating and physical activity in type 1 diabetes. Type 2 diabetes, a little bit different. We put healthy eating, physical activity as the first top two. And then we also talk about weight loss. Well, how do you usually lose weight? Healthy eating and physical activity. If, let's say, your A1C is not off the charts, we're going to promote healthy eating, physical activity, weight loss if it's appropriate. If it's not changing adequately enough, then we may include some medications, and we also at times may also include insulin. A lot of times people with type 2 diabetes, I'm never going to take insulin. All insulin is a hormone replacement, so it wouldn't be surprised if over time someone may need to take insulin. You've just had diabetes 20, 30 years, you're a little bit more insulin resistant, not making enough, we're giving you all the medications, your A1C is still a little bit higher, we may actually give you some insulin. It doesn't mean you failed anything, it just means you're living longer with diabetes. Lifestyle interventions are the key to living and staying healthy with or without diabetes medications. A lot of times when people take diabetes pills, diabetes medications, they have a tendency to say, well, I'm taking a pill for my diabetes, I can eat and do whatever I want. If it were only that easy. All right, unfortunately, it's not. It is still a combination of if you're taking medications, we still need to talk about healthy eating. We look at carbohydrates and how much food that you're eating. We talk about regular physical activity. There's some data right now. A lot of people are weekend warriors. Still some data that, that might be okay, but reality, we're looking at minimum of 30 minutes, 5 days a week, right? Weight management. Now, stress management. Notice stress management is on here as well. We know that stress can raise blood sugars. Stress can raise inflammation, which also can wreak havoc a little bit. So what are you doing for stress management strategies? Are you doing yoga? Are you exercising? Some people look for exercise in stress management. Are you doing any mindfulness? Are you going out with friends because you find that relaxing? All right, now I talked about regular monitoring. Now, people with diabetes, when I use that word, you think we're talking about finger stick testing. All right, that's part of regular monitoring if need be, but we're also talking about going to your provider routinely. All right, diabetes in many times is a silent killer. We don't know that we're developing complications until it may be worse than if we have been going to the doctor, getting our A1Cs as frequently as we're supposed to, talking to the provider about what's supposed to be going on. All right. Now we're talking about diabetes is a team effort, right? It's a team effort between you and your healthcare team. You have to think about what can you control, right? You control healthy eating, you control physical activity, you control taking your medications, not stopping medications without a discussion, right? Unfortunately, many times here in the hospital, we do have people that come in that have stopped their medication for a variety of reasons, and they end up being admitted because of a serious complication associated with diabetes because they didn't take their medications, all right? For a lot of people, it might be the cost. Definitely that is one of the features of trying to manage diabetes is cost of some of these medications. All right, one of the things I will tell you, if cost is an issue, if all of you can go online and type in a coupon card for whatever medication you may be taking, you may qualify for some assistance from this pharmaceutical company. If you have Medicare, Medicaid, government insurance, unfortunately, the coupon cards do not work. Also, you can try GoodRx, right? That's one of the discount medications. And I've had some people use that very successfully. Some people have actually used it because their out-of-pocket cost is even less expensive through GoodRx versus if they use their insurance, right? GoodRx is not an insurance plan. Some people may stop their medications because, you know what, I feel good. I don't think I need that medication anymore. Unfortunately, your blood sugar levels still could be higher than normal. You feel fine, but higher blood sugar over time is what creates complications. So if you really are wanting to stop the medication, that is definitely worth a conversation with your provider, right? What you do control is weight loss, and I did put, oh, if it were only so easy. Because if it was only so easy, then everybody would be skinny and we would not need all of the medications that are out there today for weight loss. There's many, many different strategies for weight loss. It might be a matter of trying to find one strategy that may work for you. Sometimes it's just reducing your portion sizes. Sometimes it's looking at how many calories that you're eating. There's all sorts of really, really good apps out there that can tell you how much you should eat. One of them, which I like, is called Edo, where actually you can take a picture of what you're eating and it will tell you the nutritional breakdown of the food, how many calories, right? You also controls the strategies to prevent diabetes complications, right? Are you checking your feet every day? We know diabetes over time may impact your sense of feeling, or you may get a little cut and it can end up to be infected. Are you going to the dentist? We know there's a correlation between dental disease, and diabetes. Are you going to the eye doctor routinely? Sometimes by the time people realize that they have a problem with their eyesight, it's a much bigger problem. Now, some of you may be recently diagnosed with diabetes and you may have noticed that your eyesight was blurry. That may be because you're a little bit dehydrated, and sometimes as you get your blood sugars back to normal, your eyesight may get a little bit blurrier, but then it also may resolve itself. But you should be going to the eye doctor at least once a year if you have diabetes. So remember, this is a team effort, right? How you and your healthcare provider manage your diabetes. It is a discussion. It's a discussion of how to manage. What are you going to do? How can they help you? What's the plan? Right? What's your plan when you walk out of that office? Is your plan going to say, I'm not going to drink any juice anymore? Is your plan going to say, I'm going to resume the medication? Let's say the doctor wants to increase your medication, but you disagree with that. Have a conversation with your provider. You also want to ask your provider, what is your target A1C? All right, where is your provider, your physician, looking for that number to be? If he's looking for the number to be under 7% and you're 8 or 9%, obviously something needs to be adjusted. All right, you want to talk about those healthcare strategies. Right? If you're going for a wellness visit to your provider, have them check your feet. All right, just to make sure the circulation is good, just to make sure your skin isn't dry, that you don't have any opened areas there. Right? You also want to be up to date on your vaccines. We know that people with diabetes, when they get sick, it can be a lot worse versus people without diabetes. And this is going to be a little plug for diabetes education. Right? Once a year, even if everything is going okay, come meet with an educator just to kind of see what's new, what's old, what's hot, what's not. So when a doctor is choosing to prescribe a medication, it isn't as simple as just writing a prescription. All right. The doctor has to take a lot of things into consideration when prescribing. All right. Not only is, okay, you need a new medication for diabetes, but what other health issues may contradict any of the medications that the physician may be thinking about? Do you have kidney disease? Do you have pancreatitis? Do you have thyroid, retinopathy, GI issues, hypertension? All of those go hand in hand when a physician is trying to decide, what am I going to prescribe for you? What are the potential side effects of the medication? That's a discussion, all right? And maybe you sit there and go, I don't want that. These side effects sound horrible. In many situations, if you looked at all of the package inserts, you'd never take any medication, all right? But that's a conversation. What are the potential side effects, all right? Is the medication okay with other medications that you're taking? Does the benefit outweigh the risk? It's definitely something that a prescriber takes into consideration. How much will the medication lower your A1C? If your A1C is 9 and it's only going to lower it 0.5%, is that the right medication for you? Maybe there are other choices. And what is the appropriate dose for each patient? All right, some medications have set routines. Other medications may actually be weight-based. All right, insulin, it's not one size fits all. All right, the doses can be anywhere from a little kid to a half a unit to hundreds of units in some situations. And definitely for everybody's pocketbook, what is the cost of medication? And is it covered under insurance? Now, some of you may have already found out that, I normally take Januvia for one of my medications, and I went to get it, and I was told it was no longer covered. Usually what they do under contracts, they might say, well, I'm not going to cover Jardiance, I'm going to cover an equivalent. That's another one. And the cost today is definitely a major factor when prescribing, right? So we're not going to go through all of these classes of medications, but when a prescriber is deciding what medication to order, these are just some of the different classes of medications, diabetes medications, that the provider needs to look at. All right. Now, all of the insulins are not listed here. That would have been probably a total of another 3 other slides. These are the more common ones up here with Lantus and Toujeo and Basaglar and Semglee and Tresiba and Humalog, Adnalog, Novolog, and Hujar, right? Those are the insulins. Metformin, we all know metformin if you have diabetes. Usually that's the first drug of choice. These are some of the other names to it. Then you have your sulfonylureas. Some of you may be on those. Not necessarily a medication that we routinely use these days because it may create hypoglycemia, especially taken with other medications, but we do use them because they're one of the least expensive medications. These glanides are very, very similar to the sulfonylureas. They're very similar. They don't work quite as long. You take them when you're eating. They're a little costly, not crazy costly, but this is definitely something that some doctors will order. And then you have the TZDs. These work on insulin resistance. They're not that particularly common anymore because of some studies that they found with heart failure. However, those studies were debunked, but we just don't really routinely use them anymore. This is one of the newest kids on the block. These are their DPP-4 inhibitors. Januvia, Anglyza, Tradjenta, Nacina. We are using these, definitely. All right. Again, they can be a costly medication. Now, understand, you could be on a DPP-4, you could be on insulins. Usually, you could be on one kind of insulin and maybe a sulfonylurea. So sometimes it's a mix and match here. It's like one from column A, two from column B. These are the other 2 newest class of medications, the SGLT2 inhibitors. All right. And a lot of people are on the SGLT2s, because we've found some positive benefits behind them. All right. We're looking at heart, we're looking at kidneys. So I am seeing more and more patients coming in. Usually metformin might be the first drug, and then they're coming in on the SGLT2s, usually as their second drug of choice. A lot of it, again, is dependent upon what the A1C is, right? Now we're to the guts of this, all right? These are what we call the GLP-1 receptor and agonist. These are all the same class of medication. The difference between this one, the tirzepatide, and the others is this is actually 2 different hormones in one. All of these are actually one hormone. If you look at the names, all right, we have Mounjaro, we have Ozempic, we have Rybelsus, Trulicity, Victoza. Byetta, we're really not administering anymore, and it's actually under the generic name, not under the brand name anymore. So, same medications, different FDA approvals. So a lot of people with diabetes thinks that they can get Zepbound. Zepbound is the same identical thing as Mounjaro. Ozempic is Wegovy, Victoza is I can never say Saxenda. All right, these are GLP-1s. This class over here, this was approved by the FDA for diabetes. These, same name, different drugs, or same name, same drug, different name, were approved for weight loss. So it's extremely difficult if you have diabetes for you to get Zepbound. The doses are the same. So they're interchangeable, but from insurance end and the FDA end, they're not interchangeable. Although reality, they are identical, right? I hear this all the time. I take insulin. How often do you take it? Once a week. Those those medications, the GLP-1s, that most of them are injectable, are not insulin. They are medications that are actually in an injection form. Insulin is a hormone replacement. It is not a medication. It's a hormone replacement that you're either not making enough of, or what you are making isn't working as well as it should. So, how do the GLP-1s work? The first thing that they do is they mimic the gut hormones. And what that does is it slows the gastric emptying, which helps manage the after meal blood sugar, meaning your food isn't going through your system as quickly as it should, so you don't get as high of a post meal blood sugar level. It also makes you feel fuller after and between meals, so you have a tendency to not eat as much, hopefully. It also signals the brain to say, hey, I'm done. I'm not hungry. I don't have any cravings. So it kind of shuts that switch off. And as a result, you can also reduce calories because if you're not hungry, you don't have cravings. All right. I'm sure all of us at one point have had some sort of craving and you just got to do it. All right. Well, these medications help reduce that craving. It also helps release insulin from the pancreas. Insulin is a hormone that regulates glucose. The other thing too is that we also store extra sugar in the liver. Think of the liver as our 401k glucose savings account. And sometimes it's going to release more, and this actually slows the liver from releasing some stored sugar. All of this together is going to help lower your blood sugar. This is a little bit of a busy slide. However, it's important that when you're looking at something and you're having a conversation with your provider, all right, what is it doing for you? All right, notice healthy eating and physical activity combined can lower an A1C by 0.5 to 1.5%. So if you happen to be, let's say, 8.2, you can get this thing under 7% with healthy eating and physical activity combined, right? Now when we talk about all these different medications, right, if we look, Mounjaro has the biggest leap as far as weight loss, also as far as A1C reduction. So it has the biggest bang for the buck. And what's going to happen is, I believe sometime in 26, they're also going to be releasing a medication that has 3 gut hormones. So I can only imagine what that's going to do for weight loss and also for diabetes, hopefully. All right. Ozempic. All right. The Mounjaro and the Ozempic are the top 2 weight loss medications that were usually given for diabetes, but also remember they're a diabetes drug first, so they're also going to lower blood sugars. All right. Victoza, Rybelsus, excuse me, Rybelsus. Rybelsus is a pill. It is not an injection. All right. And again, you have about a 5 to 10% weight loss, and it does lower the A1C. I also believe in 26, Eli Lilly is going to have a pill form for a GLP-1, which also may make things much more favorable. All right. Then we also have Victoza. Victoza is an oldie but goodie. It's probably one of the first ones, not the first one around, but I think it was one of the first. And Victoza is given once a day. All right. Now, I don't see it very often. When I do see it, it's usually because of a Medicaid. Somebody may have Medicaid, and that's when they're paying for the Victoza. Trulicity, again, it's an injectable medication. Same story. All right, Exenatide. All right, that's also a GLP-1. That's the old Byetta, if somebody is familiar with that. I did put down the SGLT2 as a different class of medication on here because there is some weight loss behind that medication. All right, roughly 2 to 4%, and it does have a lowering effect of the A1C. Now, you could potentially be on one of these GLP-1s as well as an SGLT2. All right, now here's some of the other medications, the other classes of medications that somebody will take. And again, I still left up healthy eating, physical activity. Metformin is mostly weight neutral. Occasionally, somebody may lose a little bit of weight on it. All of the other ones, with the exception of those DPP-4s and a class that I rarely use, most of them create weight gain. So we have to be careful when we're prescribing something for somebody that's already overweight or somebody that we put on it and now they are gaining weight without making any changes, meaning they just said, screw the diet, I'm just going to eat whatever I want. Well, that's why you're gaining weight. On the other hand, if you're eating healthy most of the time and you're doing activity and you're gaining weight, you kind of have to look at, is it medication related? So Manjaro, all right, how do you take Manjaro? All of these classes of medication, you usually have to titrate up slowly, all right? So you usually start with 2.5 milligrams once a week for 4 weeks. It gets titrated up usually every 4 weeks. It doesn't necessarily mean that you may go to the maximum dose of 15 milligrams. If your blood sugar level is under control, let's say it's 7.5 milligrams, they may leave you there. One of the things I always get asked often is what happens if I miss a dose of Mounjaro? All right, if you miss a dose, as long as it's been within 4 days, you can take the missed dose and then just take the next one at the correct time. But if 4 days have passed, skip the missed dose and then just get back on your regular schedule. All right, so these are the different strengths of Mounjaro. Mounjaro is a one-time dose pen. So you use the pen only one time and then you throw it away. Right? It's not multi-use. All right, Ozempic. Ozempic is a multi-use pen. And again, you start at a lower dose, you're on it for 4 weeks, then you pop up to the next one, on it for 4 weeks. Now, usually on both the Mounjaro and the Ozempic, the lowest dose is not necessarily a therapeutic dose yet. They start you on a low dose just so that your body can get acclimated to it because of the potential side effects that can happen. All right. The maximum dose on Ozempic is 2 milligrams, but that's really only if it's a matter of coming down to what is your blood glucose control like. Okay. So again, Ozempic is once a week. If you miss a dose, as long as it's within 5 days. If it's more than 5 days, same thing. Skip a dose, and then you're going to go back to the regular time frame. The timing. People ask me, what time of the day should I take it? And I said, well, when's the best time of the day you're most likely to remember it? All right. For me, if somebody said take it at bedtime, well, I have insomnia. So my bedtime, if I'm lucky, is 11. It could be 11, it could be 2, it could be 1, it could be 3. So it would be a little inconsistent for me. But if they said, Mary, why don't you take it every morning? I'm pretty consistent in the morning as far as my schedule. Storage. Ideally, these insulins should be stored in the refrigerator, ideally. Trulicity, Mounjaro, and Zepbound, because they're one-time dose, they can be left out for 21 days. All right. But again, ideally. Ozempic, once it's opened, it's only good for 56 days. Right. Now, I had somebody that I was speaking to today that is getting Ozempic in a bottle, and he's titrating that dose, and it's lasting longer than the 56 days. I can't tell you if it's going to be effective at that point. All right. All the companies have done studies, and all of this information is scientific based. Unused pens, please make sure that you check the expiration date on any of your medications. If you're taking insulin, look at the expiration date that's actually printed on the bottle. All right, your pen needles. All right, your pen needles, you just don't take them and throw them in the garbage. You want to get a coffee can or a can, something sturdy, put it in. Containers full, you tape it, throw it in the garbage. Right? Rybelsus is a pill. Again, it is also titrated up over time. It is not just automatically go to the largest dose. All right. This one you need to take first thing in the morning on an empty stomach with about 4 ounces of water. And they definitely want you to wait about 30 minutes before you start eating a dose. If you miss the dose today, this morning, you don't take it. You wait until tomorrow. Victoza, same thing. Start slow, gradually goes up. Again, this is once a day. Doesn't matter whether it's with or without food. Kept in the refrigerator. Trulicity, again, it's a weekly one. Titrate it up. Side effects of these medications, pretty common. All right, nausea, vomiting, diarrhea, constipation, injection site. Makes you really just want to take it, doesn't it? Usually mild, all right, but they usually will subside over time. Part of the reason why they start on a low dose and they increase it. Usually within it, let's say you do one medication for a week, 4 weeks, and you go up, you may have the side effects a little bit of again. GI side effects, you might get feeling bloated, full. Risk of gastroparesis is where the system isn't working the food through your GI system. It's almost like paralyzed. It's not quite, but it's sitting there. It's extreme dehydration risk with these medications. Please, oh please, make sure you hydrate well. Rare but serious, okay, pancreatitis. If you have abdominal pain, elevated enzymes, gallbladder disease, kidney injury due to dehydration. If you're taking other medications that may cause low blood sugar, it may exacerbate the hypoglycemia. It can cause fatigue. It can sometimes cause mild headache. How to minimize the side effects. Nausea, limit fatty foods, fried, spicy foods, all those things we used to do when we were sick or when our kids were sick. Avoid, strong smells. Mint, ginger-based drinks, not ginger ale, not regular ginger ale. It doesn't have that much ginger in it anyway, but it's loaded with sugar. All right. Vomiting affects about 5 to 20%, generally subsides. Stay hydrated. What we would recommend there is just eat balanced, smaller, more frequent meals versus 3 larger meals. Usually that will limit the vomiting. Eat slower as well. Constipation, you gotta add fiber and you gotta hydrate. You can also do across-the-counter medications. All right, diarrhea, avoid the dairy products, the caffeine, the sugar alcohols. Right now, you want to avoid high fiber foods. All right, but again, across-the-counter medications. Once you slowly add fiber back, hopefully that's going to subside for you. All right, abdominal pain, smaller, more frequent meals is super important. Eat slowly, chew well. Now, actually, even if you're not on any of these medications, we're going to tell you eat slowly and chew well because you actually get fuller faster, even if you're not taking any of these medications, right? And sometimes even without taking these medications, smaller, more frequent meals can actually help curb the appetite and the cravings a little bit. We want to avoid gassy foods, beans, carbonated beverages. If the abdominal pain is severe and persistent, please call your healthcare provider. May be associated with pancreatitis. We obviously have to tell you about that. It's a rare one, but nonetheless, it is a potential side effect. I have people come in here that have absolutely no appetite. They're hardly eating anything all day, which means they are not getting adequate nutrition. So the other thing that we tell people to do is with this class of medication, there also could be muscle wasting. You have to have high protein, high fiber foods. You need the protein to maintain muscle mass. All right. It's not like I'm not eating anything at all. I just don't feel you have to eat smaller, more frequent meals. You might want to try adding a smoothie or soup. Smoothies, be careful if you're going to make your own. You don't want to add a ton of fruit because fruit has just had natural sugar, so it may spike the blood sugars. We are recommending avoiding skipping meals, all right? Some people lose too much weight too quickly, and a lot of that, it's just this medication literally just stop the appetite, stop the craving, and just sense of fullness. If that's the case, it might be a matter of backing the dose down a little bit so that at least you are getting some nutrition. Site rotation, injection, site reaction. Where do you give it? You can give it your stomach, your thighs, and the back of your arms. We would tell you to rotate the sites. You don't want to use the same site all the time. Yeah, eventually that site's going to go, I am tired of these shots, and it's going to bother you. Please make sure that the injection site is clean. Could be soap and water, could be alcohol, right? If you have irritation, you can apply a compress. You can consider adding a topical cream like a hydrocortisone, but that would just check with your healthcare provider just to make sure that adding that is okay. A little bit shouldn't raise blood sugars. We do know that hydrocortisone can raise blood sugars, but the little topical amount that you may be given shouldn't be an issue. But again, you definitely want to ask your provider, behind that. All right, black box warning. All of this class of medications have this black box warning. It's possibly associated with a particular type of thyroid C-cell cancer. All right, it is rare. They also have not been confirmed in humans. They've only seen it in the rodent studies. All right, also, if there's another type of cancer called medullary thyroid carcinoma, or in what we call multiple endocrine neoplasm syndrome, definitely contraindicated in that. It's rare. If there's a family history or a personal history, you're not going to take it. Now, a lot of people see the word cancer. Remember, it's a particular type, but if you get a lump in your throat or swelling in your neck, or you're having trouble breathing, or your voice is hoarse, definitely reach out to your provider, right? Let them do a little research on that. Are you eating enough when you're using the GLP-1s? Do you need to change your eating habits? All right. Now, some people will take this class of medication and their eating habits, they haven't lost their appetite. All right. It happens. All right. It may just be, I can't tell you why, but hopefully it's doing a good job, at least on their blood sugars. What do we need to do? First of all, physical activity helps retain muscle mass. Remember, we talked about that protein. All right, you need to do the resistance. You need to make sure that you're hydrated. All right, water, balanced diet. This is not, I'm not going to eat any carbohydrates at all. We're telling people you want to do the whole grain carbohydrates. All right, your food choices have to be intentional and healthy. And what a lot of people will do is they will take the dinner plate, all right, and they may choose, okay, I'm going to do half of my plate, maybe not a large plate, but a smaller plate at least. Half of my plate is my vegetables. A quarter of my plate is my little bit of starch, all right. Again, you want to do the whole grains, all right, and then the other part will be your protein. Remember, protein is important, all right. You want to limit those processed foods, all right. Why? Because they're going to raise your blood sugar higher and faster. White flour, tortillas, bagels are like the worst in the world of diabetes. Sugary drinks. I would also tell you avoid the high fat foods, avoid the McDonald's, the Burger King. If you literally did some research and you went to one of these stores and you figured out how much you're having in calories, it is a killer. All right, alcohol, wasted calories, doesn't really serve any purpose whatsoever. All right, there's again, I'm stressing the protein. Eggs, fish, Greek yogurt, all right, fiber, all right, whole grains. On a lot of the products now that are high, a lot of the foods have labels, actually have a little label on them and it will tell you, it's usually like a goldish and black, and it will tell you the percent of fiber that's in there. That's going to tell you that it is higher in fiber, so it becomes a good choice. When you're looking at your breads, all right, flax seeds, nuts, all right, I don't know what choose reads means. I'll have to figure that one out. All right, cereal that's whole grain. All right, not necessarily your Cheerios. I'm made from whole wheat. Yeah, it is, but it's been processed the heck out of it. Where there's other cereals that may be a little bit higher in fiber. Raw vegetables, chia seeds. Now, when we talk about the GLP-1 class of medications, they were originally designed for people with diabetes. We have now found that it's almost a miracle drug. We know that they have a ton of good cardiac benefits behind them. They also have a lot of good for kidney disease, prevention, minimizing kidney disease. These are some of the things that we know that they do. We know it can prevent heart attacks, heart failure, metabolic liver disease. All right, it's like the cure-all. Sleep apnea. All right, Zepbound or Mounjaro in the world of diabetes also helps with sleep apnea. So if you have diabetes and you have sleep apnea, doctor may prescribe Mounjaro. I'm not overweight, right? But it might help with sleep apnea. Kidney disease, stroke, osteoarthritis, type 2 diabetes. Can GLP-1s class of medications be used for type 1 diabetes? Well, the FDA hasn't really approved it yet, but we do know that it is being used off-label. Some providers are ordering some of these medications for people with type 1 diabetes, and they have found it to be successful. Obviously, they need to be very careful. The one thing, and I just read this last night, for this particular class of medication. It's actually, they're finding research on it as it's being very helpful with minimizing, preventing dementia and Alzheimer's. So, and somebody also just told me osteoporosis, they're also looking at. So this is almost like going to potentially be a miracle drug once they find out all the data, all the scientific evidence of actually how they work, all right? Is diabetes reversible? That is $1 million question. Early intervention, meaning your A1C is not 13 and off the chart. All right. Early intervention, you have a better chance of remission. Definitely pre-diabetes, getting it back down to the non-diabetic level. All right. And if it's managed early and identified, um, people can achieve normal glucose values without medication, but it also depends on how high your A1C is, what's going on. You know, we have somebody come in the hospital here right now whose A1C is 12%, which is very high, and he's refusing, you know, insulin, which he does need. All right. We're like, you know, you need it right now. Get working on a healthy meal plan, exercise, and get you off the insulin, get you on the pills. Can we get that person totally off medication? No one knows the answer to that one. The American Diabetes Association does not recognize type 2 diabetes as universally curable, and there is actually no global consensus. Type 1, there is no cure for it. I would love to sell differently, but there is none. Diabetes is not a choice, but how you live it is. The decisions that you make to manage your diabetes really can positively impact what's going on with your diabetes. And on that note, I am open to any questions, comments, threats, suggestions.